All right. Good evening, everybody. Thanks for coming out on a nice summer evening. Spend a couple minutes here. My name's Bill Turner. I'm one of the orthopedic surgeons here in Longview who perform these joint replacement surgeries. And I'm joined by Ashley Hawks, who's the joint program coordinator at St. John. And what we'd like to do tonight, it's kind of an informal presentation. We're going to kind of talk a little bit about joint replacements, why we do them, when to do them, how we do them, how they turn out, that kind of thing. We'd like it to be interactive. We're saving some time certainly at the end for you folks to ask and answer questions. But at any point, if a question pops into your head, feel free to ask it. I can pretty much promise you that if you have that question, other people have thought of the same question too. So feel free to jump in, raise your hand, and we'll pause and answer them. So for starters tonight, what we're going to do is kind of walk a little bit through knee and hip anatomy. We're going to focus on knees and hips because knee and hip replacements are by far the most common joint replacements that are done because they're by far the most common joints that wear out and need to be replaced. We certainly see other joints being replaced, shoulder replacements, elbows, wrists, ankles, the list goes on and on. And if someone here is interested in talking specifically about some of those joint placements, I can certainly address that. But we're going to walk through the anatomy of those joints, why things go wrong. We'll talk a little bit about what arthritis really is, and we're going to talk a little bit about what some of the treatment options are. And we'll get down to joint replacement and then some of the details about that. And talk about our Joint Center program and how things turn out there. So let's start with knee anatomy. The knee is a hinging joint. Its primary job is to be stable under us, be a shock absorber, and to be a stable and mobile joint that's trustworthy. The way the knee joint's built is the thigh bone basically comes down, gets broad, has two large knuckles that sit on top of the shin bone, which is like a broad platform. And because it sort of divides into two knuckles, there's really kind of an inside half and an outside half of the joint that we see here and here. And then those are the two main contact areas where the joints rub on each other. There's also a contact area between the kneecap and the thigh bone. So when things seem to go a little haywire in the knee joint and the joint surface is in trouble, we can tell that by talking to you and you telling us it's in trouble. We can also tell it by examining your knee joint and seeing what its abnormalities are, and then we'll take an x-ray. And just to give you an example of what that might look like, this is a comparative two x-rays of a knee joint. This is an x-ray of a normal knee joint. We can see it's a nice straight joint. We can see those two big knuckles on the end of the thigh bone, and we can see a very even space or gap between the two bones. That's not empty space. That's actually where the gristle or cartilage is. That's the tread on your tires that protects your bone throughout your life. When that joint surface wears away, then the bones move closer and closer together, and we can see in this x-ray that there's really no space at all left between the two bones compared to the other side. We can see that the angle of the knee has changed. It's become much more knock-kneed, and we can see how white that bone is. The bone's really reacting to that extra pressure and trying to add more calcium in and become dense and durable. So that's the hinge joint of the knee. A hip joint's a different joint. It's a ball and socket joint. The socket's actually part of the pelvis, and the ball is on a little stalk at the end of the thigh, at the top of the thigh bone. So if we come to the top of the thigh bone, we see this big bump right here. That's that bump you can feel on the side of your hip. At that point, all your big walking muscles hook on there. The bone makes a 45-degree turn. A few inches later, there's the ball sitting in the socket. So that's a universal joint. It can move in lots of different directions. And when things go wrong in that joint, not only does the joint hurt, but interestingly, in these ball and socket joints, we see a more significant loss of motion. So people with an arthritic hip joint complain not just of pain, but stiffness, inability to get their shoes and socks on anymore. So here are two comparison x-rays. There's a healthy ball and socket joint, nice round ball, matches the socket nicely. There's that nice gap going around there. That, again, is that healthy cartilage protecting the bone. And when things have gotten bad, we we're down to really no space at all between the ball and the socket. And again, the bone gets very white as it reacts and starts to add extra bone in. So we use that word arthritis a lot. Everybody uses that word. What does it really mean? Well, technically, the word just means inflamed joint. That's not very specific. When we talk about arthritis, what we mean is there's something wrong with that joint surface. That nice, healthy, shiny, tough, gristly surface that doesn't have any feeling and carries you through your life. If it's breaking down, wearing away, it's damaged by some disease or by some injury, and it's no longer able to do its job and protect your bone, or if it's simply not there anymore, that's arthritis. There are many types of arthritis. The most common in this country is what we call osteoarthritis. It's particularly common among Caucasians. About 6% of us are going to get that at some point in our life. It's more common than congestive heart failure. It's characterized by just wear and tear. The joints just wear out, and it's usually the big weight-bearing joints that do that. So the knees, most commonly, hips, the low back, shoulders, the thumb joint, those kinds of things. So that's osteoarthritis. There are other forms of arthritis, certainly. Rheumatoid arthritis is one example, which is more of a disease where there's inflammation that attacks the joints and causes damage to the joints. There's what we call traumatic arthritis. Traumatic arthritis is where there's been an injury that damages the joint surface and sets in motion a long, drawn-out process where the joint just can't repair itself and begins to wear out gradually. Regardless of which type of arthritis a person has, as things get to the point where they're really worn out, they all start looking very similar. They all feel very similar. Okay, so what are our treatment options? If we've got a joint that isn't working right, isn't doing its job, starting to affect the quality of our life, we begin to look for some solutions. And this is stuff that your uncle or your grandmother or anybody would sort of tell you, but these are things we start with. Giving it some rest when it needs rest, exercising to maintain flexibility and muscle tone, keeping our weight under control, taking various medications, pain medications, anti-inflammatory medications, that type of thing to help control it. Injections, usually injections are a cortisone-type medicine that goes into the joint to try to dampen the inflammation response and remove the pain, or at least some of the pain in the joint. Those often work, but not always, and never forever, but they can help buy us some time sometimes. There are a variety of other types of injections or medications, and more of them all the time. Maybe you've heard about stem cell or PRP injections and that type of thing. They're becoming more and more heavily advertised and made available to people. There's very limited amount of evidence that those are really helpful consistently. Most of us in my field tend to be a little reluctant to recommend those kinds of treatments. We'd like to see really reliable results from them before we can strongly endorse them. Using assist devices like knee braces or canes or crutches obviously can be helpful depending on what our expected activity level is. Everybody's different. Some people have reached a stage in life where they're not very active, where they get to the store once a week, and so they can use a cane and get around pretty well and survive with a bad joint. Other people still are in the working part of their life, or they have places to go and grandkids to take care of and things, and they just can't be slowed down that much. So all of us kind of reach a point at a different time when we say, you know, the quality of my life is just not good anymore, and so I need to look for a different solution. And when all else has failed, that's when we talk about surgery. Joint replacement surgeries have been around a long time. The first really modern hip replacement was done in 1962 in England. The first relatively modern knee replacement was done in about 1974. So these are operations that have been around a while, that have been evolving over time, both in terms of surgical technique, in terms of the materials that are engineered into the joint, and in terms of the care that we provide the patient and how we help them through this process. And it continues to change even to this day with constant improvements. These operations are becoming very common for a couple of reasons. One reason is that here in America, all the baby boomers are hitting that age now where joints are really starting to wear out. In addition to that, we're doing a better job of keeping people healthy and keeping ourselves healthy. So we're seeing a lot of people in their 80s and sometimes even 90s who are vigorous and active and still enjoying good health other than their sore joints. The other reason that these are becoming more common is that the engineering has gotten better, and so the joints are more reliably durable. We have an expectation that they're going to last longer than they did 20 years ago. And that opens the door for a little younger patient to get a joint replacement. Just this week, a 41-year-old got a hip replacement because he needed it, and it was a terrible joint, but that's a pretty young guy to be thinking about joint replacement surgery. So overall, as we look back on our experience with joint replacements, what we happily can report to people is that with both hip and knee replacements, the success rate's high. It's over 90%, often 95%. And that's not success defined by the surgeon who says, yeah, I think that turned out great. That's actually the patient who says, I like the way it turned out. I would go back and do that again. I would rate that as a successful operation. So let's talk a little bit more about knee replacement surgeries. Probably this year we're going to cross the 1 million threshold per year in the United States. It's steadily increasing, between 5 and 9% increase every year in the number of these operations done, simply because more and more people are wearing their joints out. We call it a knee replacement, but I don't like that name very much because it sort of implies in our head, we think, well, somebody's going to come in and take my entire knee joint out and stick some big hinge in there. That's really not what the operation is. The concept of the operation is to put a new surface on the joint, because if we think about it, that's what's wrong with the joint. It just needs a new surface. So when we go into the knee joint, we go in and kind of circumvent around the kneecap and the main muscles. We remove the worn surface of the joint on both the thigh and the shin. Actually has a model of it here. So basically, the amount of bone that gets removed is relatively small. It's just enough to allow us to make room for a new surface that goes on the joint. So the end of the thigh bone gets a new surface, the top of the shin gets a new surface, and in between those two is a plastic spacer, which is in effect a new cartilage. That's the bearing surface that people walk on. And it reproduces the hinging function of the knee joint, but the knee's kind of magical. It isn't just a hinge. It actually can rotate a bit. So we don't put a solid hinge in. We put in something that can do the same thing the natural knee does, which is adjust to different positions on the ground and as we turn and rotate. And I made that sound simple, but the engineers have spent decades figuring out how to make that happen. So that's what a new knee joint looks like. The carpentry involved, if we've got a knee that's gotten out of alignment, is we make corrections. We straighten the knee back up and get the pressure running back through the center of the joint. The ligaments that stabilize the joint, the muscles that operate the joint, even the bone itself really is preserved. And for that reason, after the surgery, within 6 hours or so, we have patients up walking on these joints after that operation. There are, some people have heard about different approaches or ways to do the knee surgery, ways to get in and out of the joint. Is that something anybody has heard about or has questions about? Very simply, I'll say that there's sort of one main approach into the knee joint. There are 3 slight variations on how that's done, and all turn out well. So it's not really something to worry about too much. There is a subset of people with knee arthritis who only have arthritis on one side of their knee joint. That's about 1 out of every 20 people with a worn-out knee. One side's worn out, needs to be replaced. The other side's fine. The kneecap's fine. Those folks are candidates for what's called a partial knee replacement. You guys heard of partial knees? So partial knee replacement is just like a full knee replacement, except we're only replacing the one side that's diseased. So what that looks like is this. You still have your natural joint surface on one side, but on the other side, we've replaced that worn surface on the thigh, replaced that worn surface on the shin, got that little spacer in there. It's literally half of a knee replacement. That also has a high success rate in properly selected patients. The recovery from that surgery is just like a knee replacement surgery, slightly faster because your knee's been through a little bit less surgery. And we'll talk about the recovery a little bit in a minute. So that's a kind of a cinematic or a diagrammatic picture of the difference between the full knee replacement and the partial. Okay, we'll move on to hip replacements. As I said earlier, it's a ball and socket joint. So when we're going to put a new hip joint in, it's a slightly different technique and a slightly different approach, but the same concept. We want to get a new surface on both sides of the joint. So in the case of the hip, what we do is remove the ball. We sneak into the hip joint by going around the main walking muscle so we're not disturbing them or disconnecting them. We enter the hip joint. We remove the ball because it's worn, it's not round anymore. And then we smooth the socket. Thank you. So with the ball removed, the socket is then relined with a new bearing surface, perfectly round again, nice and smooth, nice bearing surface, very durable. In the upper part of the thigh bone, we create a little slot inside the bone and insert a titanium stem that wedges into place. And that serves like a piling under a building. That's the support for the new ball. So any size ball that properly matches the socket can be inserted, and then you have a nice round ball in a round socket that can move naturally again. Thanks. Mm-hmm. So that's a hip replacement. The goal of a knee replacement is to, yes ma'am?
How do you keep the resurfacing?
Uh-huh.
Do you cement them in, glue them in?
Oh yeah, how are they inserted or attached to the bone? Yeah, good question. For hip replacements, the vast majority of hip replacements can be done without any glue or cement. There's a special surface on the implant that under a microscope looks like the marrow part of our bone. And so when it's in place against your bone thinks that's bone and begins to grow into it and actually glues itself to it, anchors into it that way. With knee replacements, the majority of those are done with some cement. And the cement isn't adhesive glue. What it is a sort of a filler. It fills in all the tiny little defects in the surface of the bone so that when you step down on it, the pressure is perfectly evenly distributed. Much like if you were putting tile down, you put a little underlay under it first because you don't want dead spots under the tile. Over time, that tile would loosen or break. So this thin layer of this polymer cement goes in a knee replacement to perfectly spread the pressure out so it wears longer, lasts longer.
Is there different kinds? Because I heard somebody said there was different kinds, and one of them she's allergic to and the other one she's not. So are
different kinds of like hip replacements or?
No, different kinds of adhesive.
The cement?
It's different kinds of?
Different kinds of the cement?
Oh, kinds of cement?
Yeah.
Well, there aren't too many different kinds of cement. It's a material called polymethyl methacrylate, which is like an epoxy. You mix things together and it forms a cement. And there are different manufacturers make it in slightly different ways, but at the end of the day, it's the same cement. Yeah.
So you wouldn't have no allergic reaction to any of that.
Yeah. So. And we use it not just in joint replacement surgeries, but other things too. But it has its functional uses in orthopedic surgery. But for what we're talking about, it's almost always knee replacements, almost never hips. It wasn't true 30 years ago, but things change definitely over time. So the job of a knee replacement is to correct alignment and to restore that nice range of motion of your knee and give you a sturdy joint. The purpose of a hip replacement is to improve your motion, give you back that motion that the arthritis took away from you, relieve your pain, and give you a nice stable gait again. And those operations are, as I said, generally successful for doing that. You may have heard, if you read about or think about hip replacement surgery, you may have heard about different surgical approaches to enter the hip joint. And some people talk about the anterior approach, the posterior approach, the anterolateral approach, so on and so forth. To summarize it very briefly, and I'll answer questions, all surgical approaches to the hip were really refined in the 1940s. And of course, like everything else, get further modifications and adjustments and little technique changes. But the basic concept of how to get into a hip joint we figured that out 70 years ago. So none of the approaches are new, and all work well. And there are surgeons across the country who use one or the other, and every time somebody publishes an article and says this is how they turned out, they all come out the same. So every patient's different, and all surgeons are trained in all approaches, so we basically try to pick the approach that's best for the patient. I'm happy to answer more questions about that if you have them. Yes, sir.
On the hip, how big of an incision do you have to make?
How big an incision we have to make? How big of a patient are we talking about?
Me.
Because that's sort of the answer to the question. If I have a 5'1" female who weighs 97 pounds, the surgery can be done to about a 3-inch incision. If I have a 6'7" guy that weighs about 280, it's going to be closer to 6, 8 inches. So it just depends on the anatomy.
A little over 6 foot, 215 or so.
Yeah. So the first answer is I would guess about like that for somebody that's about 6'2".
Just right here.
Yeah. It could be the front or it could be back on the side. It's about the same incision either way. The second half of the answer is it doesn't matter. We have a saying in medicine that scars heal from the side to side, not end to end. So what's interesting is it's the only part of it you can see, right, is the scar. So that's why people pay attention to how big their scar is. And certainly nobody wants to make an 18-inch incision when a 4-inch incision will do. But studies have shown that the biggest problem with incisions is when they're too small, not when they're too big. Because if we try to shrink the incision too much, we simply can't see. Or we're stretching tissue that we could actually more gently move out of the way with a little larger incision. So we've learned our lesson actually about 15 years ago when we got into this kind of thing about minimally invasive surgery, and people began to push the envelope on how small the incision could be, and we began to see worse results. So everybody's kind of moved to the right size incision. Does that answer your question? Yeah. Okay, great. So there are 3 approaches to the hip. They all work pretty nicely. So that's an overview of joint replacements, why we do them, how we do them. I'm talk for just a little bit about recovery, and then Ashley's going to talk to you about the program there at St. John and how that stands out in so many ways. Just briefly, the typical recovery involves a short stay in the hospital for most people. We'll talk a little more about that. You go home. There's a period where you're resting, recovering from your surgery, but you're already starting to walk and get moving. And after about 2 to 3 weeks' time, in most cases, people are able to get in a car and drive and get someplace to an appointment or get to the store. And somewhere around 4 weeks, people are starting to move away from canes and other assist devices and really outbuilding stamina with knees still working on motion, which is really important. Oftentimes at about 6 weeks, people are getting back to work and really feeling like their day is starting to look normal again. And the most common thing I hear people say at 6 weeks is, I'm still building my stamina. I'm still trying to get my strength back, but I'm enjoying my new joint. I still think about it every day. I try to be nice to it, but I'm encouraged by the way my life's getting back to normal. And then somewhere around 2 or 3 months down the road, people say, well, I think I've pretty well got this whipped. Okay, so Ashley's going to talk a little bit about the actual joint replacement program at St. John, and then we'll answer questions.
All right. So I'm Ashley. I'm a nurse. I've been a nurse at the hospital for about 8 years now, and I have been with our total joint replacement program my entire nursing existence. So back in about 2011, we put together our what we call our total joint replacement program at PeaceHealth. The surgeons have been doing surgeries there for a very long time, but we put together this nice patient-centered, streamlined joint replacement program to hopefully help give everybody the best recovery, best outcomes, the preparation, all of the stuff I'm going to talk to you about here in just a second. Kind of pulled that all together to give you guys the best experience going through the total joint replacement. So with our total joint replacement program, there's really 3 distinct phases of care that you go through. The first one's before surgery, or the preparation phase. Then there's the hospital phase where you have the operation, and then the recovery phase, like Dr. Turner was talking about, and that's after you leave the hospital. So I'll just kind of briefly go through each one of those to kind of give you a snapshot into what you would experience going through our joint replacement program at the hospital. So the before surgery phase, or the preparation phase, is very important. This is really where we get you tuned up, geared up, hopefully excited for this surgery. So we do what we call patient optimization. You work with the surgeon, you work with your regular doctor to make sure that you're in as best shape as possible for this operation to give you the best outcome, drastically decrease your chances of any complications after these kind of surgeries. So what they're thinking about is making sure your blood pressure is under good control, diabetes is under good control, you're at a healthy weight. All of those things together, if they're well managed before an elective surgery, provides you with that really good outcome afterwards. So those are things they're thinking about. The prehabilitation, or kind of the rehab before this, is just making sure that you're in as best shape as possible in terms of strengthening your arm muscles, your leg muscles, maybe doing some physical therapy, but really working through and doing as much as you can leading up until surgery. We know we have sore joints, and that's why you're here, to get those fixed. But doing those little things really does make a big impact on your recovery afterwards. So there's some before surgery exercises that we'll teach you and go over that kind of stuff ahead of time. You have time to prepare. A couple weeks before your planned surgery, we have you come to what we call our pre-op education class. I teach that class over at the hospital every week. We have a physical therapist that comes in and an occupational therapist that comes in, and all of us give you as much information and guidance that we can think about to really help you prepare and get motivated and excited for this surgery. So things that you can do ahead of time: prepare your household, making sure that you have nice walking paths, thinking about equipment that you may need ahead of time that you can get. So all of these things we're thinking about well ahead of time you can do and prepare, and it just really makes your transition from the hospital after you've had your surgery back home so much easier. So a lot of that stuff we'll teach you during our education class, and of course it's there to help patients that are a little nervous about going into one of these big surgeries. So we really can be there to answer all of your questions, make sure we can help ease that anxiety as much as we possibly can. So my role is the coordinator of our joint program, and I really just think of myself as an advocate and a support person for each one of our patients as they come through. So kind of like a nurse navigator, I guess I've heard people call it that. So I'm here, I meet you well before the planned surgery. I get to be a part of your care throughout the entire thing. So during the education class as well, we have a patient guidebook. I brought some examples, or some of them, with me today. We have a knee and a hip replacement guidebook, and really it just serves as a resource guide for patients as they go through this. And patients really enjoy that book. It helps you prepare, and it helps you well along your recovery path afterwards also. So I have some of those with me. All right, so we get you prepared, and then we have you come in for our to have your operation. And really our hospital experience is really team-based, really a team approach. There's a lot of people that you're going to interact with as you go through the hospital. And our main goal is to make sure that all of us are on the same page, giving you guys the same consistent information and messaging, education before you leave the hospital. So we have a really dedicated team approach to this program. The other great aspect of our program, you think about being in the hospital, you think about being sick, in the bed, not a pleasant experience. We try to make this the most pleasant that we can for you guys. So we kind of name it our wellness program. So we have you come in, we don't make you wear the hospital gowns except for when you have the surgery, but we let you, get dressed in your own clothes. We keep you pretty active during your hospital stay. So like Dr. Turner was saying, you're up 6 hours after he does the procedure. So up early mobilization, we get physical therapists in to work with you right away and just get that recovery going as soon as possible. So we do physical therapy with you one-on-one. There's a physical therapist that does an evaluation with you, and then after that, we incorporate you into what we call our group physical therapy classes. We do those twice a day while you're at the hospital, and it's really just a fun experience for patients as they're going through this recovery afterwards with other joint replacement patients during the same time at the hospital. So that's kind of just a fun aspect of it. And then education, it's very important. We give you a ton of information ahead of time, and then we just reiterate that information to you at the hospital before you leave to make sure you got everything in your tool bag to go home and be successful. So lots of education. So when do you go home? Really, it's patient dependent on how things go, how they progress, but most patients tell us, about 85% of them tell us that they're ready to go home the next day after their surgery, usually by the mid-afternoon hours. They've gone through all the exercises. They know how to get up out of a bed, out of the chair, get to the bathroom, kind of do all those functional things, get dressed that you're going to need to be doing when you get home. And then pain's under control and whatnot, and then that's when we let you guys get home. So it's usually about a one-night stay in the hospital. If not, then, you know, we do it all over again the next day with you. We don't kick anybody out too early. And then once you do go home, though, I will call you. I'll probably be the first one to call you if you don't call me first, but I call all of our patients after they leave. Dr. Turner's office is obviously a fabulous resource as well if you guys have questions, concerns after you leave the hospital. So there's lots of resources once you go. Follow-up visits that you'll have with the surgeon's office. And then one of my favorite parts about our joint replacement program is our reunion luncheons, which those are every quarter. We will invite all of our joint replacement patients back for, you know, after about 3 to 4 months after you've had your joint replacement, we'll invite you back for some lunch at the expo center that we have here in town, provide a lunch for you, and really just see how things are going, allow you to give us your feedback on how things went and how things are going and how the program went for you. So it's great to see all of our patients at that time frame giving us their great stories and successes as well. So do you have any questions about what happens, the hospital portion of it? Okay. So I'm going to let Dr. Turner give you some. We have a great program, and I'm kind of biased because I'm there all the time, and I love our program. So he's going to prove to you that some of the results that we have.
Yeah, so, do you have a question?
Well, it says for the hip severely limits the activity.
Say again what?
A candidate for the total.
Oh, who's a candidate for what is? Yeah, so
severely
limited activities. Yeah, so how do you define that, right? It's different for everybody. And it just comes down to what's the quality of your life. You know, what the x-ray tells us is what's the problem. But the x-ray never tells me when to operate. I never operated on an x-ray in my life. I just operate on people. So the telling moment is when you have a good understanding of what's going on, and you have an understanding of what your options are and how we might expect that to turn out. What are the risks? What are the upsides? What are the chances of success? And if you've got all that information, then you're the one who's going to come in one day and grab me by the shirt or somebody and say, okay, I've had enough, it's time. I'm severely limited.
You know, like I get up and walk, I'm like limping within 5 or 6 steps. Okay.
Yep.
Work in my yard, walk 3 miles, no problem.
Yep.
So
Good days and bad days. Yep. And there's a point, it starts off as a nuisance, and then it starts to change what you can do, and you notice that there's a couple things you can't do anymore, but you can still do all that stuff, and then one day you look at your list and you're like, wow, there's a lot of stuff I can't do anymore. I'm not playing golf anymore. I'm not climbing the bleachers to watch my grandkid play baseball. I'm not doing stuff that I care about, and then that's the moment.
Well, I first noticed my problem in 2011. So how long is the progression? Is it different for each person?
It is. It is. Yeah, so we can just kind of talk about averages and typical stuff, but you know, when you get started on the recovery, if everything is going like it should, most people say I'm back doing pretty much everything in 2 months. A lot of stuff sooner than that. We get people who tell us routinely that before they leave the hospital that their pain's changed already. They can tell the difference. But then most people don't, I think, underestimate how much strength they've lost going into the surgery, and then they're a little surprised that, you know, 6 weeks later they're still working on their strength. But, you know, it can come back. It sure can. I wanted to kind of underscore something Ashley said about the value of the education thing that we do ahead of time. Our goal is that you have no surprises. And when you come in and everything's just like you thought it was going to be, and you're seeing all those familiar faces, what happens is your stress level goes down. And when you're not as nervous, you can just let yourself get into what we're doing, and and then folks get up and they take those first steps and they realize, hey, this is going to work, and it's off to the races. We have people who come in the morning and they're ready to go home that night. They don't even stay the night. As Ashley said, we don't kick people out prematurely. We actually keep track of a statistic, which is how often do people have to come back after they went home, and it's less than 1%. So we make the right decision over 99% of the time. And when I say we, it's the surgeon and the patient and the therapist, everybody sort of thinking about it together. We all usually vote yes at the right moment. Okay, so we can tell you all night long about how great we are, but how do you actually prove that? How do you know you're doing a good job? So here's how you do that. A couple ways to do it. One of them is Medicare, CMS, keeps track of a lot of important quality data from hospitals all over the country, and you can get online and you can look at that kind of stuff. In addition to using those kinds of statistics and comparisons to see if we're doing okay, we also are part of a program that involves about 200 other hospitals that also have joint replacement programs. And we share our information, we share our ideas, and when somebody's doing a little better than we are, we look over their shoulder and see what they're doing that's different, and we try to see if that works for our patients too, and vice versa. People learn from us. So when we look at those kinds of things, we look at a whole lot of quality data. I won't bore you with it, but I'll just show you a few little things that we look at. So let's just look at how long people stay in the hospital. Now, why is that important? The reason that's important is you don't go home unless you're doing great. You're ready to go home, right? So if you're going home fast, it means everything went smooth, just like it was supposed to. So when we look at our data, basically, this is kind of the goal of what a really good hospital does. This is kind of what people do on average, a little over 2 days. And this is where we are. We're floating around underneath a day and a half for our length of stay. I think I got that right. Yeah. Yep. So short length of stay means things went really smoothly. How often do people go home instead of going someplace else, like to a nursing home? There are places in this country where half the patients coming out of a hospital that had joint replacements end up in a skilled nursing facility for a while, or a rehab center. But in our facility, we're at the point where about 95 to 96% of our patients are going straight home. How did we do that? Well, we did a good job educating them. They knew that they want to go home. That's their goal. We help it make that happen by good preparation. So we're doing as well or better than 90% of all the other joint programs we compare ourselves to. Another thing that is probably, if you ask 100 people, what are you most worried about with a major surgery of any kind? I don't want to get an infection. I'm worried about infections. And I wish the infection rate was 0 for all operations, but the problem is we walk into the hospital with 10 billion bacteria on our bodies and in our bodies. So there's an opportunity for infection for everybody. But we know what are the risk factors that really increase the likelihood. We work hard to mitigate those things, and we're able to hold our infection rate below 1% at our hospital, which is better than the national average. It's about half the national average. So we're doing really well with that, and we're on a really good streak right now. It's been 18 months since we've had a patient with a joint replacement infection at St. John. So that summarizes our little introduction to the joint program and to the concept of joint replacement surgery. I appreciate everybody's attention. This is a good time to ask questions if you guys have any, or concerns about stuff, things we didn't cover.
Can you do 2 knees at once?
Yeah.
Oh, great
So the question is, can
Great
you have
question.
both knees done at the same time? You sure can. It's not that rare. In my own practice, every surgeon's a little different, but in my own practice, I looked it up one time a few years ago, about 1 out of every 9 people that I do a knee on, I do both knees at the same time. So why would we do that? The answer is because both knees are bad, right? And so your choices are, I'm going to have a knee replacement, and then I'm going to come back and whenever and do the other one, do it all over again. So studies have shown that if you're a healthy, this is important, if you're a healthy individual, you don't have any big risk factors or things that make us worry about you necessarily, and you're motivated, you're doing it for all the right reasons, then the chances of you having a complication are no greater with a double than it is with a single. The length of stay is basically the same. It's like 4 hours different. The amount of pain you have is the same, not more. The recovery time is faster than the guy who has 2 bad knees and just had 1 operated on, because his other knee's still bad 6 weeks later.
Good point.
So there are a lot of reasons to have both knees done if you're a healthy candidate and you think ahead and plan ahead a little bit. We've done both hips too, not quite as commonly, but it has happened. Other questions? Yes, sir.
What about a hip and a knee?
Yeah, simultaneous hip and knee is more challenging, and the reason isn't the surgery. If you're moving along and your team knows what you're doing, you can get through those 2 operations in a reasonable amount of time without significant impact on the patient's health. But the issue is in the recovery. The recovery for a hip replacement is to get up and walk on it and start getting it back in shape and let it regain its movement by walking. The recovery for a knee replacement is to go easy on the walking at first, because knees kind of get mad at you after the surgery and they want to get stiff. And stiffness is the #1 reason people are unhappy with knee replacements. So we focus on motion, and we sacrifice walking at first to get that motion going, so that knee's resting and happy and getting better every day. So the 2 recoveries work against each other with knee and hip, and that's why we seldom do that. Other questions?
What's that?
My wife wants knee surgery done, and I want to know how long I should take off work, if I should take off work.
How long
How
off
long
work?
should he take off work to help her?
Good question. Well, there's an interesting study that was published not too long ago on people who went home by themselves from a hospital after having joint replacement surgery. And if they got some support and some help, they did just as well as everybody else. So there's sort of 2 answers to your question. In many cases, you don't need to be with her 24 hours a day, more than a day or so, in many cases, because people are actually mobile enough when they go home to get to the bathroom, to get to the kitchen and heat something up or get a drink of water and see to themselves for their own real needs. I don't recommend that necessarily, but that's a necessity for some people. So for you, you're going to want to stay home for a few days just to make sure everything's going okay, and so she doesn't get too mad at you, thinking that you're bowling or something. But once you see for yourself that she's getting around okay and she can do for herself for a period of hours, then you could be getting back to work. I have some people who'll take, because they can, they've got the time, they'll take a couple of weeks off, and then by then their spouse is tired of looking at them and they really want them to go do something else.
Good question.
Other questions?
To get set up to get in this group, you just call you.
That's a great question. To get set up for...
Oh, sure. Well, so as I said, I'm the director of the joint program, but I'm not the only surgeon who does these operations. So one thing you want to do if you're thinking, boy, I've got a bad joint, do I need a knee replacement, or I actually already know I need one, I just need to start talking to somebody about doing it. Well, there are, besides myself, Dr. Kretzer, Dr. Kung, Dr. Lin, and our group do joint replacements. Dr. Kretzer and I are the only ones that do hips, but everybody else does the knees and shoulders and whatnot. Dr. Young over at PeaceHealth does knee replacements as well. So first thing is kind of figuring out who you want to go see. And once you've got that figured out, let's say if you want to come to this office, then you pick up the phone and call my office and get an appointment. And for the majority of, it depends a little bit on the insurance, but for the majority of insurances, no referrals necessary. And if you call my office or Dr. Young's office or whoever, the first question you can ask is, do I need a referral to come see you? And if you tell them what kind of insurance you have, we can answer that question in 30 seconds. And oftentimes, even if you do need a referral, we'll go ahead and make your appointment for you so you've got it, and then we'll get the referral. And the other thing that I always try to tell people is, just because you came to our office doesn't mean we're going to tie you up and drag you over and operate on you. The decision to have a surgery is yours. Our job is to educate you and take care of you. Mm-hmm. Yeah, and we can tell that with high accuracy, partial versus full knee replacement. We can tell a lot about that just from x-rays, and sometimes we do some other little studies to see. But when we go in to do a partial knee replacement, we always have the full knee replacement on standby. So we never get caught without what we need. If we need to convert to a full knee replacement, we're ready to do that.
How quick does the process go? I mean,
So how quick is the process from I decided I want to have surgery to having a surgery?
Yep.
Yeah, good question. So it depends a little bit on your schedule because you're looking at your calendar and thinking about when you want to do it. It's not a ruptured appendix, so you get to kind of pick your time. It depends a little bit on the surgeon's schedule and our availability. It depends a little bit on the time of year. This time of year is summer. Most people are trying to avoid this operation if they can, enjoy their summer. So the wait isn't very long in the summer. It can be 3 or 4 weeks. We get in, the first time it rains at the end of September, the phone starts to ring. And from there until the holidays, that's when everybody wants to do it. Like 6 weeks or a little more. But generally, we have the capacity and we can get people into the pipeline and get things moving for them. As Ashley said, once we've set our surgery date, as we get to about 3 weeks ahead of time, things begin to happen. We're going to that class, we're getting some lab tests done. If you've got a history of some medical conditions, we've already kind of figured out if those are going to impact our chances of success and starting to do things about that if we can to optimize them.
Do you have a list of all the doctors?
A list of all the doctors.
Yeah,
the
so
surgeons.
there's a couple ways to do that.
Yeah.
You can just, for my group, you can just look up on the internet Longview Orthopedic Associates, and there we all are. PeaceHealth Medical Group that employs Dr. Young, they have a website as well, and you can find her on that. So those are the docs that work in this community and do the joint replacements. And each of us have a little biography. You can kind of see what we do and what we don't do, I guess. We got, in my group, we have people who just specialize in foot and hand surgery and that kind of thing as well. So is that a good answer to your question? Okay. You can also just pick up the phone, call my office, and say, I need to talk to somebody who does knee replacements, and we'll make that happen. Or you can sit right there until tomorrow morning, about 9 o'clock. Can I answer any other questions from anyone? Great. Well, again, thanks for your time. It's a beautiful evening. Get out there and enjoy a little bit of it. If you have other questions down the road, you think about some things, Ashley is available. You just need to call the hospital and ask for Ashley, the joint program coordinator, and they will. Absolutely.
Yeah, absolutely. Yeah. Yep. And I put my phone number in those bags that I handed out to you.
Yeah, and the very first page of the book also has Ashley's contact information. And these are books that are kind of the companion to our joint program and kind of goes hand in hand with it. All right, well, thanks again, everyone, for coming in. Good luck to you.
I heard you talking about a hip replacement over here. Oh, be careful.
I might need a vote.
Yeah, no, don't say